So now, what Dr. Patyal has emphasized is that you can have well-done fields and they may be poorly reliable. And then you could have fields which have not been done well in terms of reliability indices, and the fields may be reliable. So don't jump to conclusions, and to avoid errors in diagnosis, this is what you got to do. This is what a Humphrey single field printout looks like. There are parts to this field: the reproducibility, the reliability, the grayscale, the total deviation, pattern deviation plot correlated with the raw data. Look at the global indices and the glaucoma hemifield test. So read the visual fields sequentially and coherently. If you're an Octopus user, there's just a change in the placement. The reproducibility and reliability is at the bottom, the grayscale, the comparisons, total comparisons, the raw data, the global indices, and this baby's curve is different. But you got to look at all parts before you do that. And if you have an Octopus, you have the option of a Humphrey type printout on the Octopus. There are parts: look at the reproducibility, the reliability, the grayscale, the total deviation, pattern deviation, raw data, and the global indices. So look at all parts of the field before you draw an inference. We never diagnose glaucoma from the fields. When you have seen all parts of the field and you have a working diagnosis, come back and correlate the visual field change with the expected change you would expect on the optic disc. So the visual fields need to be correlated with the optic disc. That's an essential part. The third thing you got to do is, when you get fields, read all parts, and when you look at this, you find there is a nasal depression, a superior nasal, inferior nasal involvement. But never look at the field printout of one eye in isolation. Ask for the other eye, especially in the exam. The examiners are there to help you, and they want to see people who ask. So when you ask for the field printout, keep the right-hand field on the right side and the left-hand field on the right side. So the temporal and nasal sides get easily demarcated. If you look at this right eye, the nasal side is involved. Look at the fields of the left eye, the temporal side is involved. So moment you see a lesion like this, you're thinking in terms of a neurological examination. You will in your clinics ask for a radiological examination, and the MRI picks up an old right PCA infarct. So step by step. When you see a patient like this with a field printout, you've seen all parts of the field, and you're focusing now on the pattern deviation plot, there's a superior hemispherical depression. If you're thinking in the context of glaucoma, you would expect marked changes in the inferior pole of the optic disc. Now when you see the optic disc and you find that the disc is normal, it was actually a large patch of choroiditis which was producing this superior hemispherical change. It fulfills all your Anderson's criteria. It's a reproducible field defect, significant enough, involving the macula, and this patient was actually on treatment simply because a clinical correlate had not been done. So remember that the disease of the cornea, a lot of inflammation in the anterior chamber, a bound down pupil, lenticular changes which are localized, anasteroid hyalosis, hemorrhages in the retina, retinal changes, optic nerve, all the way up to the brain can produce a visual field change. So you must correlate this clinically. There's another side to it. Just because the patient comes to you in the clinic with a visual field printout does not mean he has a glaucoma. He may be visiting you in the glaucoma clinic with a visual field printout, does not mean he has a glaucoma. So make sure you examine the patient. Now in the context of a macular disease, you usually do not need visual fields because the lesion can be seen directly. But if you're doing a study, yes, visual fields are often used to assess and change over a period of time. Now visual fields will be done well, can have an abnormality, which could be an abnormality of doing, or it could be a true defect. If it is an abnormality of doing, it will go away if you repeat the field. So this is a patient who had a lid artifact, lid was taped up, and the field defect has now, superior paracentral scotoma has disappeared. So make sure that there's a clinical correlate and you repeat. So again, emphasizing, you must take a proper history, do a slit lamp examination, correlate it with the with the applanation tonometer and the corneal thickness. Make sure you've done a gonioscopy, looked at the optic disc. That's where you make a working diagnosis. Visual fields will prove or corroborate your diagnosis. Digital imaging will come after the fields have been done. So we have looked at the three aspects: intraocular pressure, we have looked at optic disc, and we have looked at visual fields. These are the classical triad that you use for diagnosing glaucoma. But glaucomas in Indian eyes are different from glaucomas that you see in Caucasian eyes. Angle closure is much more predominant in our patients as compared to what we see in Caucasian eyes. So again, gonioscopy becomes an integral part of the diagnosis or the workup that we are doing for our glaucoma.